TopMedTalk.
Hello and welcome to TopMedTalk Down Under. I'm Andy Cumpstey and I'm here again with my co-host Kate Leslie at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine's annual scientific meeting in Brisbane. Again, this is a really big annual scientific meeting. There's hundreds of people milling around this fantastic auditorium all around us. And there's a really big research theme, isn't there, in the meeting, Kate?
Yes, it actually is a scientific meeting. We've got various streams. We've got the abstracts and posters. We've got oral presentations with prizes for fellows and also for trainees. And we've got a fantastic couple of sessions from the Clinical Trials Network with some breaking trials that we're going to talk about now. And we also have presentation of research that's been funded by the ANZCA Foundation. So I guess now we should just jump right in and talk to our three gentlemen here who presented their wonderful breaking trials today. So I'll get each of you to introduce yourself. Jay, you're up first.
Thanks, Kate. Great to be here. I'm Jay Darvall. I'm an anaesthetist and intensive care specialist at the Royal Melbourne Hospital, and I've got an affiliation at the University of Melbourne as well. And my study that I presented today was the CHEWI trial.
So I'm Lachlan Miles. I'm a staff specialist like Jay in anaesthesia, but at Austin Health, which is a slightly smaller hospital a bit further out in Melbourne. And I also have an appointment in the Department of Critical Care at the University of Melbourne. I presented the NATO study, which examined associations between non-anemic iron deficiency and treatment outcomes following colorectal cancer surgery.
Excellent. And Stefan?
Yeah, my name is Stefan Dieleman. I'm a consultant anaesthetist in a different state for a change in New South Wales, in Sydney, Westmead Hospital, and affiliated with Western Sydney University there as an associate professor. I originate from the Netherlands and I still have a strong research connection with that, and that's where the trial I presented, the DEX2 trial, was done combined with sites in Australia. And the DEX2 trial looked at the effect of dexamethasone on patient outcomes in cardiac surgery.
So it was a fantastic session, years of work by all of you. And I guess at the end of the podcast, we'd like to reflect on, how that's affected you. But why don't we start off with a deeper dive into your research, Jay? Tell us about CHEWI.
The CHEWI trial was, indeed, the culmination of a long research program that we've run looking at postoperative nausea and vomiting, a common complication of general anaesthesia still today, despite lots of great drugs that both prevent it and treat it. We did a major randomised multi-centre non-inferiority trial looking at chewing gum as a treatment for nausea and vomiting after surgery versus what is probably the standard of care, the gold standard drug ondansetron, which is used for treating nausea and vomiting that occurs after surgery. So we conducted the trial in 17 centres around Australia and New Zealand, and we enrolled just shy of 860 patients to the study. Yeah.
Wow. And so for the benefit of our listeners, could you explain non-inferiority?
I've learned a lot about non-inferiority trials through the conduct of this one. Essentially, and it's probably more common in the pharmaceutical industry, non-inferiority trials are set out to assess just that, a new treatment versus what might be the standard of care to show that it's no worse. And if that is the case, then it may be more acceptable to take up a new therapy. It's quite complex. It involves setting a non-inferiority margin, so a level of performance of your new therapy at which you determine that it's not inferior to the existing one, and then you go out and do it and do a lot of complex stats and see where you land.
And what was the result of the trial?
Yeah, so we ran the trial and managed to recruit not quite our target, but we got 84% of the patients we wanted to enrol in, and we had a definitive result, which was not the one that we were expecting or perhaps hoping for, but we did indeed find that chewing gum chewed in the recovery room for 15 minutes after nausea or vomiting occurs was in fact inferior to ondansetron. So it managed to cure, and by that I mean it resolved the nausea or vomiting with no recurrence and no need for rescue treatment. It managed to cure that in about 30% of patients versus ondansetron, which managed to do so in just shy of about half the patients treated.
So do you reckon that CHEWI is better than nothing?
That's a great question. We don't know from this study. We didn't compare it to what would more commonly be known as a placebo-controlled trial, where you have a sham treatment or a treatment with no active effect. So we can't answer that question definitively. We deliberately didn't include that arm. We thought it probably wasn't appropriate to not treat patients with anything. That's not to say that hasn't been done even in recent times. There are placebo-controlled trials versus more standard treatments, which show around about the same effect though. About 30% of patients will get better with a placebo treatment. So it's probably on or in the same magnitude as giving them a placebo. Yeah.
It's an interesting treatment though, because if you'd shown that it was not inferior, you could have also pointed out that you don't need a drip and that people quite like it, and it's very acceptable to the nursing staff.
There's some of the endpoints we did look at in this study, and we've certainly shown that it is an acceptable, safe treatment delivered in the recovery room, and that might have implications, in parts of the world perhaps where drugs are too expensive. Certainly much of the developing world, these drugs cost a lot of money, and as you say, they do need an IV to administer. So it's not to say that chewing gum doesn't perhaps have a role in the medical context, but perhaps not for postoperative nausea and vomiting after laparoscopic or breast surgery, which is what we're studying.
Oh, well, congratulations, Jay. It was a neat kind of idea, and you've added something, a small chink to the great big literature on POND.
Thank you.
So moving on to you, Lachie, can you tell us about NATO?
Yeah, so NATO was a prospective observational study, fundamentally a cohort study, and it was born largely from the patient blood management movement. Most people would recognise that iron deficiency anemia, being end-stage iron deficiency, is associated with worse outcomes preoperatively in terms of looking at postoperative outcome across a variety of different types of major surgery. And there had been a little element of mission creep associated with this message, and people began to believe or hypothesise that non-anemic iron deficiency, that is iron deficiency in the absence of anemia, might also be associated with worse postoperative outcomes, perhaps though not quite to the same degree as iron deficiency anemia. And as a result, a variety of consensus statements and best practice guidelines were published really on the basis of limited evidence advocating that this construct should be identified and treated prior to surgery. So we identified that there wasn't great quality prospective evidence confirming an association between non-anemic iron deficiency and worse outcomes after a variety of different surgical populations. We tested it previously in cardiac surgery, and this was our attempt to look at non-cardiac or major abdominal surgery. So this was conducted in non-anemic patients according to the World Health Organization criteria, having elective colorectal cancer surgery, both colonic and rectal. We defined iron deficiency in the first instance as a transferrin saturation of less than 20%, and an iron replete state as equal to or more than 20%. And our primary outcome was days alive and at home on postoperative day 90. We recruited 422 patients to the study, and the results were somewhat surprising. We found that patients who were iron replete, that is to say they had a transferrin saturation of equal or more to more than 20%, actually had a worse outcome technically, spending 1 day fewer alive and at home at postoperative day 90. This was a very, very surprising finding and not something that we were expecting at all. We've tempered our findings somewhat. I'm certainly not wanting to suggest on the basis of this findings that there's a biologically plausible reason why this could have occurred. But I think we can say that our primary hypothesis that iron deficient patients do worse has been disproven.
It's an interesting question. I was thinking about while you were speaking, is another study you could do would be to replace the iron in the people who are deficient and then compare them to people who were replete at the beginning. I think that work has already been done and had a similar result.
Yeah, not in the non-anemic population, but you're absolutely right, Kate. This is now starting to be studied in larger randomised trials looking at preoperative anemia. At the moment, there are probably 3 reasonably sized trials in the literature. There's the ANZCA trial by Keeler and colleagues, the PREVENT trial by Richardson colleagues, and the FIT trial by Talboom and colleagues. And these largely show the same things. Patients who've got iron deficiency anemia treated preoperatively don't seem to yield a benefit, at least in terms of a patient outcome benefit, in the acute postoperative period. So despite the fact that we treat this construct preoperatively, they might not necessarily do acutely better. There was one secondary finding in the PREVENT trial that suggested that patients in the intervention group had a lower incidence of readmission at the 8-week mark. But this is a secondary outcome in a trial of which the primary outcome was negative, and so it would really serve to be hypothesis generating more than anything else and the subject of future work.
So can you describe your trial design again? Tell the listeners how that might have affected your results.
So we did a prospective observational study. There are two things to bear in mind. The first is the definition of iron deficiency that was used, and the second is the covariates that were put into the statistical model that we used to analyse the results. Now, the covariates that we used were age, sex, Charleston Comorbidity Index, the CR Possum score, approach to surgery, laparoscopic, minimally invasive or open, and finally, whether or not the patient required neoadjuvant therapy in the preoperative period. Now, one plausible explanation for this very unexpected result is that there is an unmeasured confounder associated with this. This trial, of course, is observational. It's not randomised. And, of course, the miracle of randomisation means that all of these unmeasured confounders in large randomised trials largely get filtered out through that process. And we don't have the luxury of that. So almost certainly there's something we haven't accounted for in the model, which is why I'm very reluctant to attribute causality to this finding. All I'm willing to say is that our primary hypothesis was disproven.
Yes, we often quote Donald Rumsfeld in this space, and so there's really unmeasured confounders that you know about that you didn't measure, and there are things you don't know about that you didn't measure.
Yeah.
Is there anything that you wish you'd measured and included in your trial, in your study?
I think the short answer is yes, but do I know what that thing is? I don't. We conducted a pilot study where we looked at an exhaustive number of variables, trying to work out what was going into the final model, and we picked anything with a p-value of less than 0.25 to go into the model subsequently. So we had a very low bar in terms of getting access to the model. But of course, there are a million things you could potentially include in the model, which you've failed to do so. And this is very much what Rumsfeld would have called an unknown unknown. I don't know what it is. It would take an awful lot of work to try and figure it out, I would think.
Well, it was a great study, and best of luck with figuring it out in the future, Lachie.
Thank you, Kate.
And Stefan, tell us about DEX2.
DEX2 is all about the topic of the use of dexamethasone or broader steroids in cardiac surgery. As the name suggests, there's a DEX1 study, which was done in the Netherlands about 10-50 years ago, which was published in 2012, which sort of originated from the common practice in the Netherlands, but also some other Western European countries, Japan, North America, where steroids were commonly administered in a high dose in cardiac surgery to prevent excessive inflammation and thereby improve patient outcomes, which was very common, but not based on any good evidence. So we did the DEX1 trial, which was a 4,500 patient randomized controlled trial just in the Netherlands. So, in the context of a practice where the steroids were very common. And that study had a primary outcome of major severe complications, which was a composite of death and organ failure, which showed a trend towards benefit, but no statistically significant difference. So technically it was negative, but in a lot of secondary endpoints, there was quite a strong signal that indicated the potential benefit of dexamethasone, as well as quite a good safety profile with no increased risk of infections. So one of those pre-planned subgroup analysis looked at age, and it really showed in younger patients a potentially significant benefit of dexamethasone. Our hypothesis was that in these younger patients, inflammation might be a bit more severe, they might be more immunopotent still compared to the very elderly one, and they might receive more potential benefits, so are more likely to sort of overinflame and therefore have benefit from steroids. So we thought it would be good to follow it up with a second trial, which was DEX2. So DEX2 specifically looked at patients under 75 years of age. It had a bit of a special design. We wanted to do it very cheap and very efficient. So what we used was what we called a practice preference randomized consent design, which sounds very complex. But essentially what the design does, it sort of acknowledges local practice. And we did it across two countries with two different practices. So the Netherlands, where steroids are still very common, and Australia, where it's really uncommon to use steroids as a routine in cardiac surgery. And in each of the countries, the randomization was 1-2 preferring the local practice. We used a sort of a real-world way of approaching it. So we used data that were already collected to make the data collection very efficient. using registries that exist in cardiac surgery and cardiac anesthesia in both countries. So essentially it was a registry-based trial. Then we randomized patients to what's normal, which just didn't require any consent from the patient apart from allowing them for us to use their data, or 1/3 of the patients to an alternative or experimental treatment, which would be leaving away dexamethasone in the Netherlands and would be giving dexamethasone in Australia. And that requires an initial step of consent. But you can imagine that having to get a full consent from patients for just 1/3 of your study population is much more time efficient compared to having to get a full consent from everyone. And not having to collect all those data, but just using the registries was another step. We aimed for 2,800 patients to randomize, but we were hampered a little bit, or quite a bit actually, by the COVID pandemic, which essentially stopped the research in the Netherlands for about 2 years, and also for a shorter time, but a significant time in Australia. So we ran out of funding, had to stop early. So we eventually randomized just under 1,900 patients. All very comparable in terms of baseline characteristics, and the primary endpoint for the study was days alive and at home in the first 30 days, or home days, if you want to say it more simple. A very patient-centered endpoint, looking at, avoiding a complicated post-operative course because of inflammation. And, well, unfortunately, there was no difference at all between the two groups in our trial. So there was not the signal that we expected based on previous results from DEX1. We couldn't find any difference there, apart from a slightly shorter stay in ICU, but that didn't translate in more days at home patients.
But congratulations on doing a binational study with such an interesting new technique. It's fantastic, Stefan. Yeah. So in the last few minutes of our interview, I'd love you guys to rap about, what the journey's been like of being the leader of a large multi-centre trial. Years of preparing before you started, and then getting cracking on research, and what you learned. So how did it affect you, Jay?
Oh, well, it really was years. And Kate, I know you were integral part of the journey up until to this trial, but there were probably 3 or 4 preparatory studies over the last decade that we've done. Survey research, small proof of concept, then a pilot trial, and then ultimately the grasp for funding, some successful, some not successful, to run this thing. So I learned what a long preparatory phase is required before running a large multi-centre randomised controlled trial. I also learned not to start a large multi-centre randomised controlled trial just before a global pandemic. I think that was poor timing on behalf of the steering committee. We must have words. Particularly one that's reliant on a large number of elective surgical patients coming through. But it was, in another way, glass half full, a unique lesson and experience in how to navigate that and all the challenges. And I think all of us that conducted research during that period have probably been fortunate in a way, in that we've got some skills in thinking creatively, moving laterally, bringing alternative sites on board, supporting sites that perhaps aren't in lockdown with elective surgery shutdowns a bit more than others. So, it was great fun, and I've learned a real lot through doing it.
Lockie, how about you? How did your journey affect you?
Look, in many respects, my journey was easier than Jay's, purely because during the pandemic, cancer surgery largely continued, and a substantial proportion of Jay's patients who were having non-cancer surgery weren't accessible for him to enrol into the trial. The other component is that we didn't have an intervention. This is observational work. And so really, in many ways, it was a great gateway for smaller sites around Australia and New Zealand who perhaps were research curious but had never really participated in large multi-centre research before, to really get an opportunity to come to grips with the beast and learn what it's like. In many respects, it was the gateway study that hopefully will lead on to larger and more complex interventions, and these sites will feel confident in participating in those trials. And so we had 4 or 5 sites, all rural or regional. Just off the top of my head, Rockhampton Base Hospital with Diego Moriera. We had Bendigo with Angus Lee. We had Ballarat with Chamath De Silva. We had Albury Wodonga with Robert Smith, all first-time investigators.
For our international listeners, these are large regional towns in farming communities around Australia.
Yeah, who previously hadn't had the opportunity to participate in research, but they were very enthusiastic, and some of them were our best recruiters. So it's just been great to see these sites come online, and hopefully they'll continue to contribute to our network and may even become leaders themselves. Once they've caught the bug, it's hard to uncatch it.
Isn't it just? How about you, Stefan? In fact, may I say, you were the lead author of DEX1.
Correct.
So
yeah.
Dex 2, you went back for another,
I know.
drink at the well.
Exactly. I've been on the steroid journey for about nearly 20 years now. So,
Wow.
so it's been very long.
You must have been a small child when you started.
Pretty much, yeah. In the Netherlands, you can do that while you're training still, so that
Yeah.
really makes it efficient. So, yeah, what have I learned? Compared Dex 1 was really easy. Not easy, but easier because it was so just in the Netherlands, very small. You can travel everywhere within 2 hours, so you can sort of be in touch with your centres very, very quickly, very easily, and just show up. Here, trying to run that trial in the Netherlands from here is been a big challenge, and COVID didn't really help there because, you can just easily go there. So I think you probably the others have experienced it as well. Troubleshooting of small things takes up most of the time with trial. As long as it runs smoothly, it's all fine. But the troubleshooting of small things and putting out fires, spot fires, is really consuming so much time.
Yeah.
And having to do that from a distance is pretty hard.
Yeah.
So, but I'm still loving what I'm doing.
That's
Even
great.
after 20 years of this.
Well, thank you to the three of you. You're three of a growing group of mid-career anaesthesia researchers in Australia. It's fantastic to see, and all the best with whatever you are going to conquer next. TopMedTalk Down Under. Find links to each episode in our daily conference newsletter, on the TopMedTalk app, our YouTube channel, and our X and Facebook accounts.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.